Hello, welcome to this video. Thoracic pedicle screws is one of the enigmas which haunt every spine surgeon. How to insert them with minimal complications is what we are going to discuss today. Hello, I am Dr. Rohit Kale. I work in Premier Hospital as a spine surgeon and endoscopic spine surgeon. This video is meant for doctors, spine surgeons who want to improve their ability to pass thoracic pedicle screws. This video is not meant for patient. If you are a patient, we'll probably make another video for you. This is a more longer and a more technical video. So without further ado, let's start. Today in this video, we are going to discuss pedicle screw fixation. Any screw inserted in spine has to be studied with a few points, like what's the entry point, what's the intended trajectory, what are the anatomical relations, and what are the no-go zones. Of course, you don't want to put the screws in the wrong position and injure important structures in the process. So basically, for any screw, what we need to study is what to do and what not to do. So in this video also, we are going to do the same thing. Basically, what we are going to study is that what is the entry point, what is the intended trajectory, and what are the no-go zones, and what are the anatomical relations. Okay. Typically, the thoracic pedicle screws are inserted for thoracolumbar fractures, thoracic fractures, infections, tumors, spinal deformity like adolescent idiopathic scoliosis and other forms of scoliosis and all that. So most spine surgeons are aware of the typical indication. So there is some controversy and confusion regarding the thoracic pedicle screw fixation, simply because there are multiple methods described in literature. And there is a lot of confusion. Where is the entry point? How much medial angulation? How much craniocaudal angulation? So there are multiple papers which describe different varieties of these, and they recommend different medial lateral or craniocaudal angulations, making the confusion more. Most of the orthopedics and neuro spine surgeons, they prefer to have their own method of putting pedicle screw fixation. So this video is basically for that. We are going to study 3 or 4 papers, and we are going to discuss some methods, and then we are going to finally have our own method of putting pedicle screw. To start with, we are going to look at some of the anatomical aspects of thoracic pedicle screws. Okay, so this is a typical thoracic vertebra or vertebral levels. You can note a few things down. Most of the spine surgeons know the anatomy of it, but the things specifically to be noted are that the superior and the inferior articular facets are coronal in shape. Coronal means what? They have an anterior and a posterior surface and a medial and a lateral border. This is in contrast to lumbar spine, which have a more complicated shape, and they are oblique, and cervical where transverse orientation. Okay, so this is coronal orientation of the superior and inferior articular facet. So superior articular facet is a very important landmark which you have to find out while operating. So in this figure, you can see that the superior articular facet, when you are dissecting, is actually hidden behind the inferior articular facet behind, and it is not clearly visible, and often we have to do a small osteotomy of the inferior articular facet to expose the superior articular facet. We will come to the fact that why superior articular facet is an important landmark. Another thing which you can see in this particular figure is that the superior border of the transverse process and the lateral border of the superior articular facet. You can see the relationship of the junction between these two and the pedicle. So just inferior to that junction at this point is the pedicle. So this is an important thing to note. Another thing which is important is that the superior articular facet is at a 90-degree angle with the pedicle. So if you know the superior articular facet, the plane of it, and if you stay perpendicular to that, you are going to be parallel to the superior end plate and parallel to the and in an acceptable trajectory. Another figure from a paper, which one in this figure you can note that the lamina is at a angle of 90 degrees to the pedicle axis. So this is another thing which we are going to see. This particular figure also shows that the posterior elements, the craniocaudal angulation of the pedicle is usually at 90 degrees to the overall curvature of the spine and the posterior elements. So basically the superior articular facet and the inferior articular facet, the planes of it, the pedicle is perpendicular to it. So just to sum up, superior articular facet is coronal. It is hidden behind the inferior articular facet. So there are two types of trajectories which are described for thoracic pedicle screws: anatomical and non-anatomical. You can see in this figure, the upper red line shows the anatomical way and the lower red line shows the non-anatomical way of passing a pedicle screw. The anatomical one is along the axis of the pedicle, but it is unfortunately not parallel to the superior end plate. But the non-anatomical one is parallel to the superior end plate, but it is not exactly along the axis. This figure also shows again another way in which the direction of anatomical and non-anatomical pedicle screws is mentioned. Okay, so you can see that this is called as the axis of the pedicle, and the medial red line is the midline. So the angle which is shown in this figure is called as the mediolateral angle, or you can call it theta. So this is the mediolateral angulation of the axis of the pedicle. So this varies depending on what level you are doing. You can actually pass pedicle screws along the axis of the pedicle, but also there are two more acceptable ways by which we can pass the pedicle screw. You can take a slightly lateral entry point and you can have a more medial angulation and you can still pass the pedicle screw acceptably. You can take a slightly medial entry point and you can also pass a screw, but you have to give much less medial angulation. So in short, there are multiple possible trajectories: anatomical trajectory and non-anatomical trajectory. Anatomical trajectory is along the pedicle axis, but sometimes the axis is not parallel to the superior end plate, it is going downwards. So the anatomical trajectory needs a higher entry point and slightly more inferiorly directed trajectory for the screw. Non-anatomical needs a lower entry point and a trajectory that is perpendicular to the superior end plate and parallel to the perpendicular to the superior articular facet and parallel to the superior end plate. There are some more things, like you can take a slightly medial entry point and less medial angulation, or you can take a slightly lateral entry point and a comparatively more medial angulation. All these things are possible. So you can see the figure, you can see the superior articular facet and the line which is bisecting the superior articular facet. We will come to this particular line, but you can see that the four dots are the possible entry points. So there is a superior medial entry point, superior lateral entry point, inferior medial entry point, inferior lateral entry point. All of them can be potentially acceptable entry points. So there are actually, for every pedicle in the thorax, there are multiple probable entry points and multiple trajectories which are acceptable. So there are multiple methods by which you can put the thoracic pedicle screw. So we will basically discuss three of these methods. A variable entry point dependent on the level. So the entry point varies along the depending on what level you are putting the pedicle screw. That's probably we can call it a Lenke method. The second one is universal entry point. So you take an entry point irrespective of the level. And the third one is the confluence method. So all these three we are going to discuss. So this first one is described in this paper by Kim and Lawrence Lenke, which is basically freehand pedicle screw placement in thoracic spine. Actually, freehand means what? As little use of the C-arm as needed. As you can see in this figure, the entry point, the paper recommends different entry points at different levels. So the last three thoracic vertebrae, T10, T11 and T12, have an entry point which is more lateral and which is along the middle of the transverse process. But after T9, the entry point keeps on going medially and superiorly, so that from T5 to T9, the entry point no longer corresponds to the middle of the transverse process, but it corresponds to the superior border of the transverse process, and also it is more medially from T9 and it keeps going laterally till T5. So the upper four vertebrae, that is T1, T2, T3, T4, again have a slightly lateral entry point, and the entry point is basically along the middle of the transverse process. So these are basically entry points which correspond to the axis of the pedicle, and basically we want to try to put the pedicle screw in along the anatomical, that is the axis of the pedicle. Okay, so T1, T2, T3, T4, the entry point is slightly lateral and along the middle of the transverse process. T5 to T9, the entry point is along the superior margin of the transverse process, and T6 and T9, they are more laterally, and in the middle, that is 7 and 8, there are slightly medial entry points. Okay, so this is a bit of complicated method because which pedicle screw you are putting, you need to be aware of. You can study the plain X-ray to get an idea where exactly the entry point, which is the ideal entry point for that level. Also, you can study the CT scan in a complex deformity case, so that you can get an idea of which pedicle is which is the ideal entry point for the pedicle. So this paper also describes the pedicle diameters. So you can see that the lower thoracic pedicles have the maximum diameter, that is T10, T11, T12. You can actually accommodate a 5.5 screw easily, because 6.32, sometimes 7.8 also. Mid thoracic pedicles are comparatively smaller, especially T4. So T4 to T9, the diameter varies from 4.7 to 6.1 millimeters. So you may or may not be able to accommodate a 5.5 screw in this. So you have to study the CT scan preoperatively to ensure that you are not breaching, you are not fracturing the pedicle. So T4 to T1, progressively again the pedicles are bigger. So pedicle diameter varies from 5.6 to 7.9 as we go up. The transverse pedicle angle is also pretty variable. You can see that the angle theta, or the transverse pedicle angle, or TPA, decreases from 30 degrees at T1 to 5 degrees divergent at T12. So most of the vertebrae it is convergent, and T10 T11 it becomes almost straight, and T12 it becomes slightly divergent, 5 degree divergent, that is outward. Okay, so in the proximal thoracic spine it is about 13.9 degrees. Okay, so 30 degrees to 13.9 degrees, it keeps on reducing from 30 degrees, 25 degrees, like that it keeps reducing up to T4. At T4 it is 13 degrees, and in the mid thoracic spine it reduces from 13 to 7 degrees, and in the lower thoracic spine it becomes neutral to slightly divergent. So you can see that the lower thoracic spine, you should not have a significant angulation. The entry point, the trajectory mediolaterally should be almost straight. There should be one has to note that only in T1 and T2 there is a significant angulation of 30 degrees, but rest of the spine is just hardly 13, that is 10 degrees to 7 degrees or even less than that in the lower thoracic spine. So lower thoracic spine you should have minimal angulation. So this paper also describes the thoracic gear shift mechanism, by which you can use the curved gear shift. You can actually, to cannulate the pedicle, you can use the straight probe to probe the pedicle, or you can use the curved probe. In that curved probe, first the curvature should be outside, and then once you pass it across the pedicle, then you can make it towards the midline. You can just see how the Lenke gear shift probing is done. The curvature is first facing laterally until the pedicle, that is 1.5 centimeters, and after that you can remove the pedicle probe and turn it 180 degrees, so that now the curvature faces medially, and now you can again put it back. So important relations which you need to know is, two medially placed pedicles can enter the spinal canal and they can injure the spinal cord. Two superiorly and inferiorly placed pedicles can enter the neuroforamina and injure the nerve roots. The right-sided laterally placed pedicles can injure the azygous vein, inferior vena cava, esophagus, thoracic duct, superior intercostal vessels. Left-sided screws can injure the esophagus, aorta, lungs, sympathetic chain, all that. Okay, so this is another paper by Fennelly. This is important. It uses a uniform entry point and sagittal trajectory for all levels. So this also you should be aware of. You can see the superior border of the transverse process and the lateral border of the superior articular process, and you can find out the junction between these two. Just take 3 millimeters, 2 to 3 millimeters caudal to the junction of the lateral margin of the superior articular process and the transverse process. So wherever this junction is 3 millimeters below, you can take that as a universal entry point, irrespective of. So you can see that this is a slightly lateral entry point. So the trajectory will be slightly more. So this is the entry point for all the levels. And what is the sagittal trajectory? The craniocaudally, the trajectory should be perpendicular to the overall curvature of the spine, that is the posterior elements. So the posterior elements, like the superior articular facet and the inferior articular facet, the trajectory should be perpendicular to that the craniocaudally. And mediolaterally, what should be the trajectory? That is T1, T2, it should be 30 degrees. And in the rest of the spine, that is T3 to T12, it should be about 20 degrees. So you can note that the angulation should never be more than 20 degrees in any vertebra, especially if you have taken a medial entry point. But here you have taken a lateral entry point. So lateral entry point, and you have to give at least 20 degrees in medial angulation. There is something called as the superior facet rule. This is a paper by Lehman, where they describe the superior facet rule. Okay, so what is that? This is a paper from Spine Journal. Okay, so the superior facet rule is what? They have studied a lot of pedicles in the thoracic spine, and they realized that the superior facet can be an important landmark. So a midline, which is midline of the superior articular facet, or a line which is bisecting the superior articular facet, can be a very important landmark. Why? Because most of the pedicle axis go lateral to this, and most of the ventral lamina are medial to this. So if you that can work as a safe zone for pedicle screw fixation in the thoracic spine. You can see that the medial half of the superior articular facet. So any entry point which is medial to the medial half of the superior articular facet is a no-go zone. So there should not be any entry point. You should not accept any entry point which is medial to the midline of the superior articular facet. That's the superior articular facet rule. And any entry point which is lateral to this is acceptable, but any entry point, the entry point has to be either along the superior border of the transverse process, or it should be along the upper third of the transverse process, or maybe middle of the transverse process, but it should never be below the line bisecting the transverse process. So we will come to that later. But basically here what entry point they are suggesting is an entry point just lateral to the superior articular facet midline bisecting line. Okay, so any entry point medial to this line is unacceptable. You can see in this particular figure that if you can see the superior articular facet, any place in these lines, any entry point taken along these lines, black lines, and if you give even a slight medial angulation, they will enter into the spinal canal. So these are unacceptable entry points. So medial half of the superior articular facet is a no-go zone. So lateral half of superior articular facet has to be the entry point. Okay, so there is this paper called as SAP principal guided freehand technique. So this is also very interesting paper. In this what they recommend is that they are recommending basically superior articular facet as a guide for entry point from T1 to S1. So any level from T1 to S1, you can actually use the superior articular facet as a guide for entry point. And this they recommend for all thoracic pedicle screws, upper third transverse process and lateral border of the superior articular facet. These two are the landmarks. And for the lumbar spine, again lateral border of the superior articular facet, the midline of the transverse process, or what they are mentioning as the accessory transverse process, and a exterior margin of the lamina. These are the three lines. Wherever they are joining together, that is the entry point for the lumbar spine. Okay, so there is another very interesting paper, the slide technique. In this, this is an improvement in the funnel technique for safe pedicle screw placement without C-arm. So this is again a spine journal paper. Okay, in this, what is mentioned is that first you check the midline of the superior articular facet and stay lateral to it. Then you burr the transverse process, the dorsal cortex of the transverse process, and the anterior or the ventral cortex of the transverse process continues down or continues anteriorly as the lateral cortex of the pedicle. So you can actually use this particular continuity as a guide to, so this particular cortex acts like a slide. so that you can enter into the cancellous bone of the pedicle without a medial breach. This is a very good technique, especially in bad sclerotic pedicles. So this is another paper, freehand screw placement using universal entry point, universal sagittal and axial trajectories for all the three: subaxial cervical spine, thoracic spine and lumbosacral spine. This is also an interesting paper. They say that the superior articular facet can be a guide for entry point and trajectories for all the levels. In this case, again the same thing they are saying, the superior articular facet lateral border, just below that and the transverse process junction, that 2 mm caudal to this junction you can take as entry point for cervical, thoracic as well as lumbar pedicle screws. And the trajectory for mediolaterally, the trajectory is 90 degrees to the lamina, and craniocaudally the trajectory is perpendicular to the posterior elements. So this is the embryological basis of it. You can see that the pedicle and the lamina are 90 degrees at all the levels, and this is because they are formed by a single structure. So this is the universal entry point throughout subaxial cervical spine, thoracic spine and lumbosacral spine. Universal sagittal and axial plane technique. So there is no need for a different technique at different levels. You can use an universal entry point at all the levels, just 2 millimeters inferior to the junction of the superior transverse process and the lateral border of the superior articular facet. And you can take the the sagittal and axial, universal sagittal and axial trajectories. So there is one more method called as the confluence method. It is described in this paper, Techniques and Accuracy of Thoracolumbar Pedicle Screw Placement. In this, a triangle formed by the medial border of the transverse process, the lower border of the superior articular facet, and a pars interarticularis in thoracic spine was selected for pedicle screw entry point. An awl or a drill was used to create a hole in the pedicle entry. So you can see that the base of the superior articular process, base of the medial border of the transverse process, and the pars. This triangle, the center of it, is used. Again, the superior facet rule has to be remembered, that is, the entry point should never be medial to the line bisecting the superior articular process. So, and the craniocaudal trajectory should be perpendicular to the lamina, and craniocaudal trajectory should be perpendicular to the superior articular process, and medial lateral trajectory should be perpendicular to the lamina. So the entry point is what? Bony confluence of base of superior articular process, transverse process and pars. So you can see here, this is the base of the transverse process, this is the medial border of the base of the superior articular process, the medial border of the transverse process, and pars and interarticularis. So this is the triangle which we are talking about, and this is the midline of the superior articular process. So now they recommend an entry point which is along the line dividing the superior articular process 1/3 laterally and 2/3 medially, which is this blue line. So you can see that the papers are actually ideally either some papers are recommending slightly medial entry point, some papers are recommending slightly lateral entry points. So landmarks are SAP hidden behind. So this is basically the review of what we just now said. Superior articular process is hidden behind the inferior articular process, sometimes exposed if needed with removal of IAP. So TP base meeting the superior articular process and pars. So this is again another, the lateral border of the pars extend upwards is also one of the landmarks. Things to remember. Medial half of the superior articular facet is a no-go zone. Never along the inferior half of the transverse process. So most of the papers show that either the entry point is along the middle of the transverse process, or upper third of the transverse process, or a superior part of the transverse process. So it is never below the line bisecting the transverse process. This has to be very clear. Never too lateral on the transverse process unless you want a out screw, okay, which is usually in concave pedicles which are small and sclerotic. Never too lateral to the level of the pars. So level of the pars can also be an important landmark. So if your entry point is too lateral to the level of the pars, that is not going to be an ideal entry point. Never too medial onto the lamina compared to the lateral border of the pars. So lateral border of the pars is another thing which you can use. So if your entry point is too medial to the lateral border of the pars, and it's also too medial to the midline of the superior articular process, these two are um, important landmarks. So you can see that what landmarks you want. You want to know the lateral border of the superior articular process. You want to know the superior border of the transverse process. You want to know the line bisecting the transverse processes. So these three lines you have to draw mentally, and you can draw another line at the center of the superior articular process. So you will get a small rectangular zone. This is the zone where your entry point should lie. So you can also see this particular junction, which is the junction of the transverse process and the lateral border of the superior articular process. So this is the no-go zone, that is the inferior part of the transverse process. The entry point can never be lying in below the line bisecting the transverse process. The entry point should never be medial to the line bisecting the superior articular process. So this green rectangle is the only place where your entry point is allowed. Any entry point in the gray rectangles is an unacceptable entry point. You can also use the upwards, so lateral margin of the pars as a landmark. You can you can use this line extended upwards, which is along the lateral margin of the pars, to get an idea of how lateral the entry point is. If the entry point is too lateral to this, that also might go outside the pedicle. So things to remember: for trajectory, never go more than 30 degrees angulation in T1, never more than 20-degree angulation in the rest of the thoracic spine. So most of the thoracic spine, only 20-degree angulation is more than enough, especially if you have a lateral entry point. If you have a medial entry point along the just lateral to the midline of the superior articular process, if this medial entry point is there, then you have to give a much lesser medial angulation. Not even 20 degrees is needed. Never too much angulation in the lower thoracic spine. So in the lower thoracic spine, you have to be more careful because the cord is big, the spinal canal is small, and there is a high likelihood of medial breach. So medial angulation of the pedicle is very little in the lower thoracic spine. So T11, T10, T11, T12, you have to be really careful when you are medially angulating the entry, the pedicle probe. No-go zones for trajectory thoracic spine. There is no flexion extension because of the coronal facets. So most of the scoliotic deformities, there is vertebral rotation. So the medial lateral trajectory may be difficult to assess. So you have to be really careful. But even then, the things which are mentioned above, like mm, craniocaudally, the axis of the pedicle is perpendicular to the superior articular process or the posterior elements. So these things hold even though there is a curvature and there is vertebral rotation, and thus um, when the vertebra is rotated, the superior articular process will also be rotated. So even in case of vertebral rotation, if you stay perpendicular to the superior articular process plane and you stay perpendicular to the lamina mediolaterally, then you can be in the safe trajectory. In tumors and infective pathology, there may be a medial wall breach and a commonly felt increased resistance when you reach the medial cortex may not be seen. So you have to be especially careful. In spinal deformities and congenital scoliosis, there may be dysplastic sclerotic pedicles. So you need to be aware of that. This is especially true for T4, T5, T6, especially in the concave part of the curve. So what is the universal steps? Expose the transverse process to transverse process, define facet joints, especially the inferior articular process and the upper of the upper vertebra and the transverse process. So define the pars lateral border, extend it upwards. The lateral border of the pars coincides with the lateral border of the superior articular process, which is hidden. Okay, define the lateral half of the superior articular process base, which is often about 4 millimeters area and can offer two potential entry points for 2 mm burrs, medial and lateral. Medial at the base of the lateral 1/3 superior articular process. Lateral entry point is just medial to the lateral border of the superior articular process. Correspondingly, you can preferably choose the lateral entry point, cannulate the pedicle with straight probe or Lenke probe, whichever you want. If you expect a narrow pedicle, as in CT scan, especially in mid dorsal spine, use a curved pedicle probe. Cannulate the pedicle with gentle rotation without too much force, with appropriate medial angulation not more than 20 degrees, especially in the rest of the spine, that is T3 to T12. In T1 and T2, there you can give about 30 degree angulation. So T1 and T2 30 degree medial angulation, and rest of the spine 20 degree medial angulation. Then you have to follow these steps. First you put the pedicle probe, then you put pedicle sound, then ensure all the 4 walls, then tap, then again pedicle sound, and then pass the screw. Identifying the problem screws. When in the mid thoracic spine, T4, T5, T6, you have to ensure that you have seen the CT scan to look for small and sclerotic pedicle screws. And pedicle screws on the concave side of the curve you have to be especially careful about. And hypoplastic, dysplastic, sclerotic pedicles on the CT scan. Okay, identifying the no medial wall felt intraoperatively, or no hold of the screw. That is probably you have entered the spinal canal if you are too medially, or you have probably gone out of the pedicle laterally. So screw is touching the midline or crossing the midline on C-arm. When you have taken a slightly medial entry point and still your screw is touching the midline, that is a very bad thing. So you have taken a adequately lateral entry point and the screw is having some medial angulation, that is acceptable, but you have to be aware of giving medial angulation to the screw, especially in the lower thoracic spine, T10, T11, T12. So if there is CSF coming out after cannulation, that's also a bad sign. Also, if you have neuromonitoring, any disturbance in MEP or SSEP are you can identify the problem pedicle screws with that. So thank you for listening, and I'll see you in my next video. Thank you.